In this video, I'll be demonstrating unscrolling of DMEK graft in a hazy cornea. Preoperatively, this is a case of pseudophakic bullous keratopathy with significant stromal edema and around 5 dilated pupil. We begin by injecting the graft into the eye. We use a 2.8 glass tube to inject the scroll. While injecting, I'm being very slow and very cautious because if you use a lot of force, the graft will just come out of the main wound. We also use a cannula at the side port to just decompress the anterior chamber before injecting the scroll completely into the eye. While removing the tube as well, I use a cannula to dampen the area of injection. Once the scroll is in the eye, I just release some more fluid and I like to keep my scroll in the center and not attached to any of the structures in the angle. We try to release fluid as much as possible so that while you are taking the suture, the graft does not move out of the main wound incision. Care must be taken that the blood does not enter into the eye because once blood is inside, you can have fibrin formation. We also are using enox heparin in the BSS solution we are using so that the fibrin formation is minimal. We take one suture in the center of the incision and care must be taken that this suture is not too tight because if you make it too tight, then the curvature of the cornea is disturbed and the graft attachment might be a problem. So you just try to oppose the wound margins together. While I am taking the suture, you can also see that there are some markings on the cornea. These are the markings of 8 which is reflecting towards the graft size, and this is helping us for the centration of the graft as we do it in the subsequent steps. We spray some fluid on the cornea to look at the orientation and the configuration of the scroll. We inject some fluid inside the eye as well so that the configuration becomes a more desirable configuration, but that's not the case. You can see that the scroll is folded in a complex orientation. At this point of time, I just put enough fluid in the eye so that the graft moves, and then using the tip of cannula, I don't use the shaft, I use the tip like you see, and I'm just tapping on the scroll, and the scroll is moving as per my desire. As you can see that the scroll has come into a longitudinal orientation, and now I'm just shallowing the anterior chamber, and you can see the scroll starts to unfurl slowly. While doing so, you can also see the orientation is correct with the P mark in the center. You also want to center the graft before unscrolling it completely because it becomes very difficult once it's completely unscrolled. You pin the graft in the center and use a disarmer technique to try to open it in all the directions. You can see 90% of the graft is completely open, which is when we again try to center it to the desired position and then pin it again and use the disarmer technique again to open the graft completely. In this case, we were successful to completely open the scroll, but in hyper deep anterior chambers, we can see that the graft has moved. Well, we try to tap at one edge. So now again we are forced to center the graft. You don't want to leave the graft ectatic. So we just try to center it again using gentle tapping movements. And unfortunately, when we are doing that, the graft scrolls in again. This happens very commonly if the graft is from a younger donor and the chamber is very deep. Again, we try to unfurl it completely. The centration is more or less decent at this point of time. I'm just trying to take off any fluid in between the graft and the host bed and center it completely, slightly more superiorly, like I said, because the air bubble will hold the graft much better that way. We are checking again whether the graft is completely open. See how deep I'm pressing on the cornea. Otherwise, you cannot sometimes get a good opening of the graft. At this point of time, I'm good with both the unfurling of the graft as well as the centration of the graft. In the end, I just remove some fluid because you don't want to pressurize the chamber with air because that makes the graft move to one direction. So the graft is kept, the anterior chamber is kept very shallow before we go in and inject an air bubble. I like to inject my air bubble from the side port which is further away from the edge of the graft, as you can see. I go right up to the center of the graft. I don't like to inject my bubble in the periphery because that moves the graft in a deep chamber. So I go to the center and inject an air bubble. Once the graft is secured with the air bubble, I just increase the air bubble size to a full chamber, wait for 30 minutes, and I remove some air. This is the post-operative outcome at 1 week. You can see that the cornea clarity has improved drastically. The pupil is slightly bigger because of the cycloplegics we use. I'm sure the vision will improve by end of 1 month's duration. Thank you.